Good morning.
Good
Hey,
morning.
Narendra.
Hey, Narinder.
Excellent. Just a quick mic check. That all sounds great.
Yep, you
Yep, it
sound
sounds
great.
great. I'll be introducing you guys and giving two little notes to the attendees, and then I'm going to go off camera and leave it to you. I'm going to give us one more minute and then I'm going to start the introductions. Well, good afternoon, everyone, and welcome to the first No Hymns webinar for the 2025-2026 year. Today we have the absolute pleasure of welcoming Dr. Akram Boutros, Dr. Narinder Singh, and Dr. Steve Zhu from Nexus, LookDeep, and Sibel. And they are going to talk about redefining bedside care, a conversation with the innovators. We are going to have 1 hour of CP hymns, CA hymns credit, and there's also a one-page outline or a handout that will be available on the No Hymns website by tomorrow afternoon. So without further ado, just one more thing. If you have questions, just put them in the chat, and at the end of the presentation, we will bring those questions up for our presenters. So now, without further ado, Dr. Boutros, it's up to you.
Great. Thank you so very much, Chris. It's a pleasure being with Northern Ohio chapter of HIMSS. You've already seen who we are. Narendra has been elevated to a doctor. He's as smart as a doctor, but he's not. I'm going to try to give you about 10 minutes of what we do at Nexus Bedside. Narendra and Steve are going to each do about 15 minutes each, and we're going to leave about 20 minutes for you to ask questions directly of us. So Nexus Bedside is a combination of three things. We have developed a co-caring model that provides hybrid nursing. That means virtual nurses and bedside nurses who are not only a part of the same team, but they actually work both positions, both as a virtual nurse and a bedside nurse, alternating between them. And their co-team members are the CNAs or CTAs. We also use 24/7 ambient monitoring, computer vision. That's developed by LookDeep, so I'm not going to go a lot into that, but they are a technology partner. And we together are co-developing Amy, which is AI for me. It's the first in-hospital room multimodal vision, hearing, context, patient companion, and staff amplifier. So our co-caring model takes the primary nursing model and changes it so that a virtual nurse is working with a bedside nurse. I would say to you, most healthcare systems who add virtual nursing do so with the idea that the virtual nurse is additive to the process instead of actually changing the model. They have them be a part of the solution, but only for specific tasks rather than integrated into the entire solution. So for us, it's a bit different. There's significant responsibilities and differentiation between the virtual nurse and bedside nurse and how they collaborate together. We've redefined the entire workflow for every aspect of the care. So what happens when you do that? For us, we're optimizing nursing time. The primary nursing models, we've shown that for a 4-to-1 ratio, where a nurse is providing 6 hours, there's 6 hours of nursing time being provided to the nurse, to a patient per day. That 1 hour and 10 minutes of that, our research and assessment was really non-value added. It's interruptions, nurses looking for things that they should have handy, extra steps going back and forth, and the patient really gets 4 hours and 49 minutes. When you use our hybrid model, the bedside nurse delivers 4 hours and 16 minutes of bedside care. The virtual nurse provides an hour and a half. That gives the patient a lot more time, more care time. So direct care for a patient goes from, by the bedside nurse per patient, goes from 1 hour and 51 minutes to 2 hours and 37 minutes. If you can see the electronic medical record documentation per day is significantly reduced per patient. So instead of an hour and a half done by the bedside nurse, it's 22 minutes by the bedside nurse. So they gain significant amount of time to provide direct hands-on patient care. And nearly an hour is spent per patient of documentation being done by the virtual nurse. Admitting, discharge, transfers, and coordination. Again, we spend more time for that with that because it provides better care. And again, a lot more communication is being done by the in a combined fashion. So what happens is that we believe we're returning joy to nursing by refocusing time on what matters most. So here's an assessment of a virtual nurse's and a bedside nurse's day compared to a primary nursing's day. So waste is reduced by 75%. We provide 2 times the direct care versus the primary nursing model. In electronic medical documentation, 60+% is performed by the virtual nurse. Now, I'm not going to go much into Amy, but just to tell you, it's multimodal data ingestion, videos, audios, EHR, wearables, and other devices. Natural language interactions, 55+%. We have the ability with Amy to do auto charting for nursing. The staff must sign off on that auto charting. And we also can provide alert routing algorithms. So if there's a critical value, Amy can inform the intern, the resident, the hospitalist, the head of the department, depending on the escalation protocols that client defines. So what does the Nexus platform deliver? It can deliver virtual nursing, virtual sitting, virtual consults, and rounding. We can provide continuous vital signs monitoring, and Steve will talk about that. We always provide AI-augmented nursing workflows, integrations with different communication devices like Rover. We have third-party integration. If they have translators, scribes. We provide Family Care Connect so that the patient's family can connect with them, Amy, and we can also provide remote patient monitoring with Sibel, and we'll talk about that a little bit. So this is broken up into optional integrated modules all the way up to AI support. But what we are working on is, and I'll let Narinder talk about and Steve talk about the technologies here. But what we're working on is really the Nexus Smart Room platform. This would be the first integrated smart hospital room platform to transform every hospital room into level agnostic intelligent care environment. That means the patient comes in, they're placed on observation, they stay in the room with the bedside nurse, and we're providing virtual support. They can go to med-surg, they can move to telemetry and move to step down, all in the same room. Because we provide not only the workforce management, we provide the computer vision, the electronic medical record integration, and vital signs monitoring. And all of that is done in a single solution in which the Nexus Smart Room platform integrates all of them. There are other pieces of this, including the user interface, for example, for HVAC of the room, lighting, and other devices that are available in the room. So we are focused on robust analytics, can provide significant module usage, session volumes, session length, nurse adoption, patient feedback. They have clinical outcomes, falls, length of stay, rapid response, patient satisfaction, workforce impact, the documentation time, the virtual touches, throughput, payroll per discharge, and lots of technical uptime here. We are also the only organization that uses a CSP model, which is a client success partner that is embedded in the hospital that we are deployed in. They provide learning modules, consistently focus on staff etiquette, and we provide community education to the patients and the like. So what also makes us different is that we have a guaranteed performance on our contracts. We provide break even after all fees during a pilot, and the pilot is typically 6 months. And we guarantee a 10% reduction of total labor cost per discharge. You'll see what we've been achieving in our deployments. And by year 2, we guarantee a 20% reduction of total labor cost by discharge. These are our deliverables, length of stay reductions of 30% within 12 months, labor per discharge reduction of 20%, HCAP scores increases of 25% by a year, safety event reductions of 50% within 12 months. For example, falls with injuries in our first deployment, there was a 100% reduction in falls with injuries and a 50% reduction within the first 3 months of safety events. Nurse turnover reduction, all of these accrue to the benefit of our clients. So that's my part of the presentation. I am going to turn it over to Narinder for him to go through his platform and how it gets used by us and other organizations.
Thank you, Akram. I always appreciate the shade from a Clevelander. I am from the wrong part of Ohio, originally from Cincinnati, but Akram and I still found a way to work together, and we've proven collaboration is possible everywhere. My name is Narinder Singh. I'm the co-founder and CEO of LookDeep, and my story is a little bit of a different path. I was a career technologist involved in kind of major changes like the internet, cloud computing, decided to get into healthcare, and was enrolled back in school. And my mom suddenly had interstitial lung disease, went into the hospital for a biopsy and a couple-day visit that turned into a 12-week inpatient stay that culminated in a bilateral lung transplant. So I saw the importance of kind of bedside care at every second and couldn't shake the thought that I wish my favorite nurse, Meg, could be with my mom all the time. I wish the whole care team could be with my mom all the time. So at LookDeep, we're looking at using AI and video to enable hospitals to be ever present for every patient. And so we're thrilled to be part of this collective that Nexus is pulling together with amazing technologies like Sibel as well. And so I'm going to walk through a bit of how we do that. The first part of this, you already know. Like you've seen this, we've seen this pressure on nursing shortage. We see this burnout. The pleasure of the job has reduced. And a big part of that is because all of a sudden, nurses and doctors feel like they work for the technology versus they work for the patients and their betterment. And so we look at that and what is causing that. And so LookDeep as a platform has helped create the ability to have virtual support, virtual consults, virtual nursing, virtual fall prevention, family care connect, EICU, translators, scribes, and much more. So we have a full platform that uses video and transforms it inside the hospital and beyond to support nurses and doctors. And then we work with any hardware. So we have our own technology, but we understand the future is so diverse. You need to be able to plug into the environments that matter for hospitals. But this is not enough. Actually, it's not even close to enough because the real problem is that nurses and doctors can't be in two places at once. As powerful as our virtual technology is, the fact is you still need a nurse or you still need a doctor to go talk to that patient in that instance, whether they're in St. Louis, Cleveland, Illinois, or New York, you still have to have that same capacity set that's there. So there's improvement that's possible by having distributed, labor, but really we still are stuck in the same place. The population is aging, we don't have enough time. And so the only pathway to really unlock this is how do we help nurses and doctors be everywhere all at once? So LookDeep is the only company that has published peer-reviewed research on how vision AI can work in real hospitals. That's real patients being watched when nurses and doctors are not in the room. And so this is really fundamental to our thesis of the market, how we go from hybrid vehicles to fully electronic vehicles and the transformation that's possible if we can have AI that supports solving this fundamental problem. Okay, so how does that work? Let me give a couple of examples. The first one is thinking about fall prevention. The AI creates a safety zone around the patient, but the virtual observer can change it. They're not working for it. They can make it bigger, smaller, et cetera. So they don't lose control. And then what happens is inside of that range, it's like a wearable. We can track movement. And then if they start to get out of bed, we nudge the virtual observer to say, pay attention to this patient, something's happening. So that's a powerful foundation, but there's an even bigger layer. Infinity Watch can watch hundreds of patients in this way. So, because for the most part, patients aren't doing anything. And then it only surfaces the one that needs the human observer to say, hey, Mr. Smith, please stay in bed right now. This is how we go from the industry standard of 10 or 12 patients to many, many more by using AI to support that the way we would driver assist and to support the fleet of intervention that's possible because AI is supporting care. Now, nurses, doctors, and virtual observers can feel like they're everywhere all at once. But that's only the beginning. You can think about the opposite of that. If fall prevention is about keeping patients who shouldn't be wandering in bed, what about patients that are in bed too much? Patients that are not moving enough? Patients that have not been turned in the last couple of hours? A risk for pressure injury. So again, LookDeep doesn't tell you this patient has pressure injury. What we tell you is here's the patients that haven't been moving very much, are in bed, and no one's turned them in the last couple of hours and allowing for intervention. You can also look at mobility patterns. Like we can see in bed, even patients who are not that mobile, here's what's been happening with them. Gray line is yesterday, the blue line is today. So we can see this patient feels like they've been a lot more lethargic through the day. We can look at macro patterns, like where are they spending time? Like, so if each of these bars is a day, you can see that this patient blue is in bed all day. Okay, it looks like they started to move around. They were in the chair, they were in the room, they were out of the room, and then they had a little bit of a step back, providing context for what the recovery patterns look like. And when you zoom out and can say, if this is everybody I'm thinking about discharging in the next couple of days, it doesn't take a doctor or a nurse even to say, well, these 3 patients have been in bed literally the whole time. What are we doing to kind of change their trajectory? So this is the power of AI that supporting doctors and nurses by having eyes on every patient every moment, even when they can't. But there's a bigger problem. If you think of zooming back from hospitals for a second, the population over 70 is going to double the next 20 years. About 38% of seniors over 70 are hospitalized each year. 70% are forced to move out of their house. If you project forward to 65 million seniors by 2040, nearly $3 trillion of the healthcare spend will be just on this population, 70 and older. We can't sustain that. We need a different model for that. And what we're seeing with innovations from companies like Sibel and us is that apps and dashboards aren't enough. That's not where the next generation of innovation is going to occur. In hospitals, it's doctors and nurses can't be in two places at once. Hospital at home, it's the fact that we cannot put these kinds of monitoring at home, but we need that level of monitoring to support people. And then even for people aging at home, I will assure you, it is not the lack of apps and dashboards that keep people from aging at home. It's the lack of physical ability to pick up the groceries and get your medications. So we need AI to start to enter the real world for patients in order to have a real transformative effect. And so LookDeep has begun that. Ahmed noted that we've had the AI computer vision video piece for a while, and we're looking at how do we create engagement against that. And so rather than just talk about what Amy can do and how it can help staff and the like, I thought we would ask Amy what Amy thought. So I'm going to log in, and hopefully you guys will be able to hear me. If not, please somebody who's on mic interrupt me.
Hello, how are you doing today? How
Hi,
can I
Amy.
assist?
I'm with some friends, and they're asking, what do you do for the hospital?
I'm glad you asked. In a hospital setting, I act as a supportive presence for both patients and staff. I blend real-time computer vision and natural language to help ensure safety, like stepping in if a patient is trying to get out of bed unsafely, and I relay messages from nurses or doctors. I can also assist with things like checking a patient's comfort, ordering meals, or even providing translation for non-medical conversations. And importantly, I'm there to be proactive, not just reactive, always ready to help at just the right time.
That's great, Amy. Can you give me an example of something you won't do in the hospital?
Of course, one clear example is that I never give medical advice or make clinical decisions. For instance, if a patient asks me whether they should stop taking a medication, I won't answer that.
Well, what about if they complain about their nurse or doctor? What would you do?
In that situation, I listen carefully and acknowledge their feelings. I might say something like, I hear that you're upset. Would you like me to let someone on your care team know? I don't judge or take sides.
That's great.
But I can.
What about explaining things that are complex? Like, what if I was a post-surgery patient and I need you to explain it to me like I'm a 7-year-old, why it's important to wash my hands?
Of course. Here's how I'd do that. I'd say, washing your hands keeps away tiny germs that can make you sick. After surgery, your body is healing, and we want to keep it safe. So washing your hands is like keeping the bad stuff away from your body's superhero healing powers. Simple, clear, and
That's
easy
great.
to understand.
Amy, ਤੁਸੀਂ ਮੇਰੇ ਨਾਲ ਪੰਜਾਬੀ ਦੇ ਵਿੱਚ ਗੱਲ ਕਰ ਸਕਦੇ?
ਜ਼ਰੂਰ, ਮੈਂ ਪੰਜਾਬੀ ਵਿੱਚ ਗੱਲ ਕਰ ਸਕਦਾ ਹਾਂ। ਤੁਸੀਂ ਦੱਸੋ ਕਿ ਤੁਹਾਨੂੰ ਕੀ ਜਾਣਨਾ ਹੈ?
Actually, Amy, can you tell me what I said to you in English and how you replied? Can you translate to English?
Sure. You asked me in Punjabi if I could speak in Punjabi. My reply was, yes, I can speak in Punjabi. Let me know what you need help with.
That's great, Amy. Last question. Can you tell me what you see right now?
Sure. I can see a person wearing a blue turban and a checkered shirt, sitting in front of a whiteboard and a bookshelf. There's a couch in the background. If you have any specific questions about what I see or need more details, feel free to ask.
Thanks, Amy. So you can see, Amy can actually see what's happening in the room, like whether the patient's alone, whether they're having a conversation with a doctor, and interrupt or not interrupt, depending upon the context that what's there. So this capability of being able to see for a hospital is critical. It's not enough to just have a voice that's over a speaker because you're missing all the context of care that imagine interrupting a doctor having a sensitive conversation with the patient. But it's also what lets us say, hey, when the patient's back from rehab, ask them about their pain level. So Amy has context of what's going on and can see it every minute. and can use capabilities inside the LookDeep platform like Crystal Ball to know that even before entering the room. And so the scenarios are endless. Sometimes the way we think about this is we're trying to take the non-clinical activity and judgment, those tasks off of the plates of doctors, nurses, and others in the hospital. We're reducing their step count so they don't have to go to the room just to figure out that the patient's not even there for a conversation. We can help patients order lunch and reminisce about how their grandmother used to make chicken pot pie, and a nurse doesn't have to, who's very busy, who's trying to just get out of the transaction, doesn't have to be faced with that choice of, do I engage with the patient and talk to them in a way that spends so much time with one patient, or do I have to go to this other room that something else is going on that might be more urgent? So Amy looks after patients where they are. And so you can think about this journey of going from where you feel like you work for the technology. We've seen with AI scribes for the first time, doctors and nurses feel like that the technology works for them. We're extending that concept. We're allowing you to see what's happening. We're allowing you to actually engage in help. And in the future, even allowing you to get physical help with things like robots. When you put technologies like LookDeep and Sibel together, you're not adding the benefits, you're multiplying them. You're getting an exponential set of benefits around what's possible. And organizations like Nexus are able to change the factor of absorption of that innovation. If you look back on the history of cars, 2008 is one of the most important years in the history. It's the year that Tesla introduced and sold just 1,000 roadsters. But it showed the evidence of what's possible with a pure electric vehicle. We are at that stage with AI today. We've sold 1,000 units. It's not nearly pervasive, but we're seeing what's possible. And this is not a future-oriented technology with places like Nexus that can drive clinical leadership and change. You actually can absorb the innovations from LookDeep and Sibel today. And so that's a little bit more about how LookDeep supports that vision, and happy to answer questions at the end. And I'll turn this back over to Akram and Steve.
Well, thanks, Narinder. I'm going to turn it over to Steve if you can stop sharing, and he can talk about Sibel, which is unbelievably cool technology and that I've seen firsthand.
So thank you so much to Akram for the invitation and wonderful presentation, Narinder. Clearly for the audience, I lost the draw straws log because I'm going last after these incredible conversations and presentations, but I'll do my best to bring up the rear, talk about some of the things we're doing. I'm a physician engineer, actually a dermatologist by board specialty, but usually a head scratcher. Why am I not pushing Botox in Beverly Hills? I asked that myself as well. But as an engineer, I think skin is an amazing source of information. And it's non-invasive, and this is where I've built my career around taking that insight and technology and deriving more information so it's useful for clinicians to make decisions. So company's called Sibel Health, and quick little bit about our mission and vision. So we believe in better health data for all. Clinical decisions are based on data, and the best data provides better decisions that hopefully save lives. We execute that by delivering on advanced wearable monitoring solutions that provide actionable clinical intelligence via our sensors, software, and AI algorithms. So our big, hairy, audacious goal is that human anatomy is very complex. Hospitals take care of premature neonates to 100-year-olds at the end of life. A single sensor technology cannot monitor that vast variation in anatomy and physiology. So we make wearables for the right place and the right care context, but enable that in any acuity, on any patient, in any place in the hospital, including the home, so we can make that physiological data continuous, predictive, and interoperable. So what does that mean for healthcare systems? When you have advanced wearables that are intimately integrated with the EHR of your choice, we can provide clinical intelligence in places that are not monitored consistently, which is pretty much everywhere outside of the ICU. So that means an ER, and we have a crisis in hallway boarding in ERs, we can actually put physiological monitoring in those patients that are waiting a day, even longer for a bed. And that can address waiting area issues, hallway boarding. In the low acuity med-surg, gen med settings, we can facilitate early discharge. As a clinician myself, it's always a difficult decision. Is this patient ready to go home? When you only have vitals for the last 24 hours based on 3 or 4 spot checks, where the respiratory rate's always 14, it can be difficult to make that decision. But early discharge, even by an average of 1 day, gives a hospital of 800 beds essentially an extra 100 beds by increasing throughput. But also, we can reduce nurse burden, saving about 55 hours per year in nurse labor simply by not managing vital signs monitoring equipment, the third most common use of nurse time. We can prevent unplanned transfers by detecting deterioration earlier, reduce falls and skin injuries. We have on-sensor fall detection and turn time, as well as enable hospital to home to lower those 30-day readmissions that eat up a bed and are not reimbursed. Our core product's called Annie One. It's FDA cleared for all vital signs in patients 12 years and up. It's not just the wearable devices and technologies we'll talk about. It's bedside monitoring with alarms and alerts, central monitoring with alarms and alerts that are based on the web. So you can log in and look at your entire ward virtually. All of that integrated within the EHR. So that data ends up in the user interface that all of you use and see. Our sensors are soft, flexible, reusable, and rechargeable. So I think that's a nifty little gimmick we can do with our sensors. It makes it more skin conformable and comfortable. 7 days battery life, so nurses never have to worry about range, and ultimately allows us to cover an entire admission. All of our sensors are rechargeable and reusable, dramatically lowering operating costs, enabling hospitals to realize the value without spending $200 on a patch that they have to throw away after 3 days. Continuous ECG, respiratory rate, fall count, step count, temperature, all of it on a very comfortable, easy to use package. Comes with a single-use disposable. We also have oximetry, which is at the same level of the top oximeter makers like Nellcor and Masimo in terms of accuracy. No difference in performance and varying different levels of skin type and melanization, allowing for continuous SpO2, pulse rate, and perfusion index. So as a quick video, I will have to say we have to step up our demo game because Narinder's was very, very impressive. But if you can put on and connect AirPod, you can use our system. Everything is Bluetooth or NFC connectable, so allowing you to pair that with our tablet. The tablet itself can also alarm and alert, but pairing is very simple. It's just like connecting your AirPods. We have the ability to stream that data in real time. So for patients that are higher dependency, higher risk, you can have waveforms, single lead ECG, continuous SpO2, RR, activity, as well as blood pressure all in one place. If you don't want that in the room, shut the screen off. So that way it simply acts as a gateway to our central monitoring and alert station. We also have the ability to set alarms. So based on thresholds and personalization, the system can also alert and alarm. So if you have a COPDer that just lives at 93% SpO2, you can modify and adjust that. But in that setting where a patient deteriorates, we'll have the ability to alert and alarm clinicians that can intervene and make a difference without increasing alarm fatigue. And then finally, we have the ability to set up a ward up to 64 patients on a single screen, enabling you to watch at a floor level at the nursing station or even virtual monitoring if you have monitoring techs as part of your care pathway. That enables you to see what's happening in your entire ward and be able to monitor, shut off alarms and alerts from a central station. So bringing a tele-like light version to the low acuity floor, enabling continuous monitoring everywhere. And all of this is packageable, ready for the home with a bring your own device solution that leverages our devices. So if you're thinking about continuous monitoring in the home setting, building out your hospital to home program or hospital at home program that goes beyond spot check weight or blood pressure, we have an amazing solution that can directly address that. And then coming down the way with strong support from the Gates Foundation, we will bring continuous wireless wearable monitoring to the maternal health side. This is an area that has not seen an innovation for 40 years. We are one of the worst countries in terms of maternal mortality in OECD. So being able to bring that same solution to the intrapartum, postpartum period as well. So we're excited about the future. And just like Narinder said, wireless has replaced everything in our lives except in healthcare. So I think it's time for us to cut the cord, enable continuous wearable monitoring. AI is making these waveforms actually understandable. Instead of gibberish and noise and data that we throw away, there's actually insights. We have shipped more than 20,000 systems worldwide, touched more than 40,000 individuals, and we're using that data to allow for early discharge, to predict for deterioration, to identify patients that are likely to have sepsis. And I think that's what's exciting about what we're doing. And what makes Sibel unique is that we're not a one-trick pony. We make wearables that fit the anatomy and physiology of the patient and the complexity that fits the patient's clinical condition. And we're generating the AI algorithms that power that revolution, but also enabling others to do it as well. We have an interoperable wearable platform, all of which feeding AI. So we talked about our core product, and we're excited to be working with LookDeep and Nexus to enable that in Gen Med, Gen Surg, and ER. But we have an ICU product as well that enables continuous 12-lead ECG in real time as well as work in neonatal and pediatric monitoring. We have 7 FDA clearances. We're the only company in the world with a continuous reusable ECG and pulse oximeter patch. Our product is not only a general patient monitor, but also a clinical grade home sleep test. So if you think about patients that deserve 2 weeks of ECG monitoring and an HSAT, we actually can do that in one single technology platform. So that's very exciting and allows us to really extend care beyond the 4 walls of the hospital. And ultimately for us, we see vitals as the core solution. We're moving to predict outcomes, but then ultimately we believe in the future of hospital automation so that humans can intervene only when things are off and directly communicate with patients, delivering empathy and care that only humans can, taking technology out of the piece of care. Peer-reviewed publications at the highest levels from Nature Science to Nature Medicine. So all of our work comparing against gold standard systems, predictive algorithms are always peer-reviewed, given our academic background. And if there's ever an interest in research-based clinical care, please talk to us because we also provide raw data in our technology, enabling our customers and health systems to leverage their data to develop their own products and solutions as well. So we're happy to kind of enable that. Thank you for your attention. These are our 4 values: earnestness, execution, excellence. As a physician, always putting patients first. And we're very proud to be nerds and would love to talk to you. Thank you.
Thanks very much, Steve. So for the audience, let me just state this. We at Nexus took about 24 months to try to identify the best technologies out there to assist hospitals. There are plenty of video cameras out there, and many are coming every day. There are vital signs monitoring that's attached to the wall, or wearables of all shapes and sizes. We wanted to accomplish 2 things. We wanted to find the best of breed, literally the cutting edge of this, and LookDeep. There's nobody better, not only from the hardware side, but also the software side. And Steve's wearables are absolutely extraordinary. There's nothing that comes close to them from accuracy, comfort, long-term use, and the ability to imagine a patient who's in the hospital who's being monitored, who on the way home in the car using their iPhone can continue to transmit data to the electronic medical record and have AI determine if there's any deterioration. That's unbelievable. So what we try to do at Nexus is to put all this together in a single package, so you have a single point of contact and that you know everything is integrated. For example, alarm fatigue isn't only an issue for the nurses, it's also an issue for the patients. We can turn the alarms off on the wearables and have the iPad or the solution inside the room that only blinks, and have the LookDeep camera identify the issue there without waking the patient, so that we can tell, and a virtual nurse can immediately look at it and say whether a patient is having a seizure or a patient is turning into bed. So we've solved for all of that. And as far as the cameras and everything else out there, I don't know. But this is what I think about Nexus Bedside. Nexus Bedside is like an elite athlete who's been redefining the game, not because they have different equipment, but because of how they use it. So think of a world-class basketball player like Michael Jordan. He played the same game with the same ball and court dimension as every other professional athlete, but achieved results no one else could touch. He didn't have access to special equipment or secret training program. What really set him apart was the deep experience and uncompromising drive to be the best and a relentless work ethic. His outcomes weren't just good, they were, many say, extraordinary. So that is what the Nexus Bedside platform with LookDeep and Sibel does. We there are plenty of virtual care tools out there, but the results, our results, are really in a league of their own, and it is shaped by this extraordinary commitment and expertise and in execution and collaboration. There is very little ego between all our providers, all our technology. We want to make it work for the staff and the hospitals. So with that said, Narinder and Steve, could you answer the question, which is, because this is wireless access, and especially Steve, the Bluetooth, how is patient data protected? And Narinder, you can talk about protection of patient data and also video and all.
Yeah, so cybersecurity is a hot topic for everybody, including the FDA. So Sibel is FDA cleared, so we meet all the stringent guidances of the FDA on cybersecurity from the cloud down to the sensor level. So we do use Bluetooth, but it's fully encrypted, 256 AES. We also have NFC pairing, so that kind of mitigates like man-in-the-middle attacks. Every data stream we go from the sensor to the tablet to our central is all encrypted and follows the most recent guidances and standards. So I think ultimately, you know, the data is protected. Generally, our sensors don't handle PHI, right? So we, you know, basically have some metadata around admission discharge directly from your central server EHR as unique identifier, but it won't typically carry PHI. We put the vital signs data into flow sheets. So if you're using Epic, you know, that's the way that kind of works. And that way we sort of protect that. All of our tablets are under Knox, so that's protected. We can wipe it remotely, et cetera. Have full control over that device. So you can't watch Netflix on our tablet, unfortunately. It's kind of in kiosk mode, but we have some flexibility to deploy other solutions. But happy to connect with our IT team if there's further questions about data protection. Thank you.
Yeah, fully SOC 2 Type 2 penetration testing. We have kind of third-party hackers attempting to hack the system all the time intentionally. We just finished one of those. You know, I came from kind of the technology world, so building large distributed systems securely. So we went through that, and I think you've seen this, is that it's an interesting thing that we've seen more suspect things in hospitals than almost anywhere else, because it's still applying the old model of technology protection, which is you build a moat around the castle, but once you're past the moat, the castle's undefended. We act like everything's a point of attack inside and outside the hospital, and that makes the system more robust. Like you could put our system on the internet and it would be equally secure because we assume that every potential interaction is an attacker, and that's kind of the model that the modern cloud world kind of pioneered. So, and again, happy to share those reports and the like with anybody.
Narinder, could you talk a little bit about blurring and patient privacy and Amy and all of that?
Great questions, Akram. So one of the things is we're dealing with video, and it's a new modality. And so we basically allow for the end customer to decide store no video, store blurred de-identified video, or store full video. And we think over time, people will turn that dial to the right. Like despite kind of some of the controversy, what you find with things like police body cam is most of the time it's actually very beneficial to have that from an audit perspective. But we know that will take time for the industry to catch up with. So right now you can turn it at any level that makes comfortable for you and your legal team.
So a couple of questions. So how many languages can Amy understand and translate? We
I mean,
offer 50. You go
about
ahead.
55. I can validate 3. Akram could validate a couple more. So, but yeah, 55 languages supported across that, and that list is getting better and deeper all the time.
And Steve, somebody's asking, Wendy, I think is asking, customers that are using the Sibel system in the CMU remote operations center setting today.
Yeah, so one of our strategic investors and also customers is Memorial Healthcare down in South Florida, Fort Lauderdale. So we are running their post-op cabbage, post-heart transplant, and cardiology. So basically, the model is that for every 20 cents they spend on continuous ECG monitoring in a remote setting, especially for that high-risk patient, right? You know, complex cardiology, they're saving 80 cents in cost. So Memorial Health is a great example of that kind of remote operations setting. Happy to talk more about that with you, Wendy, if you're interested.
And Steve, can you talk a little bit about your work in internationally in Africa and how where you're deployed?
Yeah. So you know, maternal newborn health is a big passion of ours. Like they're the most common, you know, DRG in hospitals is pregnancy, I believe, right? The most common surgery is C-section.
Yep.
So, you know, we don't make our wearables just for adult patients, right? We have done a lot of maternal patients. We have a pediatric clearance, a neonatal clearance. A lot of morbidity, mortality when it comes to maternal newborn health is actually in low and middle income countries, like 97% of it actually. So we have a really large initiative with Bill and Melinda Gates Foundation around deploying the same technologies we have at Northwestern, at Memorial Health, in the best hospitals in Copenhagen and Scotland, in low resource settings in Africa. The only difference is, quite frankly, the price. So I think that really kind of gives us that confidence that our sensors are robust, rugged. They perform even in high sweat. You know, everything is waterproof, showerproof. That kind of gives us that. So I think if there's any interested, people in pediatric, neonatal, newborn, or maternal health, let us know, because they're not ignoring that patient population. In fact, I think it's part of that entire continuum.
There was a question, Akram, on full installations on Amy. Basically, the technology you saw, the computer vision, the AI, all those things are deployed at about 20 hospitals. The conversational element is actually being deployed as we speak at a major hospital with Nexus. And as you can imagine, that if you think about the size of that deployment, it's actually almost entirely legal compliance change management. So from a technology perspective, we're kind of ready to go, and we're going through those things. And that's why the Nexus relationship has been so important, is to kind of narrow into how do we roll this out effectively in it from an adoption perspective to get people engaged. So that's where we're on the cycle with that.
Yeah, and Chris, what's really important is, and I don't want to overemphasize what we do here, but from contract signing to full deployment with all of us, we can do this in 6 weeks. If the hospital is ready to engage and is able to put the staff in place, we want to do this in a sprint. We don't want to do this in over a 6-month period. So if people can assign individuals from operations, clinical, IT, and we will deploy in 6 weeks. We deployed in 4 weeks of part of our solution. Right, so it depends on how fast, and that's really the beauty of working with a single entity that can do all of that together, and that's really important. Is there a learning period for each location as you implement? We have fully so the most important maybe person who's not here is our client success partner. They are 9 to 5 on site at every location, constantly working with the staff to manage any issues, create constant training, be support, and we have 24/7 support with our 800 numbers, in which it goes to our nursing and technology leaders who provide these things. Adoption is critically important. And we reached, for example, in one hospital, we reached a 30% reduction in length of stay, and 60% throughput improvement because of the hands-on, consistent working with the staff. This is a lot about change management and supporting the staff. If the staff feels supported, adoption is great. If it's not supported, it is absolutely becomes one of those things where they feel that they're working for the technology. Narendra,
And
do you want to add?
one of the great things I think about Nexus is they don't come in day one and say, hey, here's 17 things, we're going to roll these all out. Because of that client success partner, they basically have kind of a program that's customized to the individual place to say, okay, here's the 3, 4, 5 things that are most important right now, and then here's the next ones. And sometimes those are not, so just because they have all the tools doesn't mean that they roll them all out day one. It is customized to the place, and so there's this ongoing piece because they're not doing a big bang deployment and saying, see you later, let me know how it works out. That client success partner really is about, they're a nurse and they're about there to kind of constantly add in the next piece that aligns the strategic vision of the hospital, the unit with the capabilities. And so it's kind of an ongoing and iterative process that's continually self-improving.
So you want to add the and chest piece? They will show you how to do it. They will connect the first 50 patients for you, show you exactly how it gets done, and show you how the data is used utilizing the artificial intelligence. Our paradigm is to have the technology and the solution work for the staff and the patients, not the other way around.
From Sibel's perspective, the first 6-8 weeks, we saw essentially about 85% second to second heart rate, respiratory rate coverage, which is sort of like a indirect measurement of a learning period. But after that 6 to 8 weeks, you know, we're with you on the ground. That went up to 98% signal quality second to second. So there's absolutely a learning curve just to get used to, like, patient hits the floor, get a sensor on, you know, monitor through. But, you know, it's something that really just is that initial period. It isn't perfect on the first go. We know that. It's a change in behavior. Our product is designed by nurses, built for nurses. So we really try to kind of implement that in a successful way. But there is a learning period for sure, Wendy. I'm not gonna sort of say and sugarcoat day 2 it's perfect. But I think that once we kind of enable that, you know, not having to get HR, RR, not have to wake up the patient at 2 a.m. to collect this or that, game changer really sort of makes it easier for everybody. You know?
I think Steve hits on a very important point. Recently, I was in 6 hospitals in 3 states across 900 miles. And for a lot of these smaller sites, those last mile issues are absolutely the critical ones. Like, how does it get turned on? Who does what? Who's got the responsibility set? Because they don't have departments, they have people. And so I think one of the things that's compelling is obviously we've been involved with very, very large systems and people think about scaling in that way. But for modern technology, the equally important is, can you scale down? And that's really one of the things we focused on as LookDeep is, can we make this so easy that a 20-bed rural hospital can absorb this? And the constraint, frankly, had been staffing for a long time. And so the Nexus piece kind of really rounded that out. But from a technology perspective, we know how to scale down into the smallest environments. And in fact, I think something very important that Steve said is that because if you think about the home as your destination, you have to be able to make it almost completely self-service. So we look at that as the destination, and then the usability automatically then flows through for small hospitals and, of course, the large ones.
And Megan asked about EHR integration. We can integrate into all the major EHR systems. I'll tell you, one of our probably greatest strength is Epic, because our integration staff, one of them was 15 years the chief medical officer of Epic. So we can manage the entire process with you and be able to test it without a lot of work with your staff. From your staff, we can do it, and then you give us the approval to go live. So we want to make all of this easy for you. We don't want the IT lift to be very, very heavy. We want to be able to provide it for you. So we're very comfortable with, you know, whichever major EHR that you have.
I think
So
that
we
we
have a
have time. Go ahead.
Sorry. Just quickly, yeah, we have a HL7 fire, integration protocol. So pretty much every EHR has an EHR be able to ingest that. I think we do some unique things with Epic that are sort of a specific area of expertise. Like for instance, to be able to leverage Rover to file alerts, for vital signs. So I would say any EHR platform, although we can do some unique things with Epic. So if you're an Epic house, I think we can talk a little bit further and deeper about opportunities there. Over.
And Wendy, yes, Epic TV, Epic Whiteboards. Let me just say this to you, because I know we're mostly technologists here. As our VP of nursing says, every unit is different. So to just plop in technology and say, hey, what can you do with it? Is you're not going to get the results. We working with the frontline staff, unit leadership, to create workflows that are specific to that unit. And that's why we get the results that we do. And we will integrate only the pieces that make sense initially, as Narinder said, and then we deploy as people are more comfortable additional utility. So, Chris, if there's one or two more questions, I see my friend Christina Janice is on here. Can't believe she hasn't asked me a question.
Yeah, nice to see you, Dr. Boutros. Actually, I could even put my camera. I could really see you. Unfortunately, I had a meeting overlap with this, so I'm like, oh my goodness. But I definitely will listen to the recording. I know I missed out on some great content, but thank you so much for presenting to us. Greatly appreciated.
You're very welcome.
Are there any more questions? We can take those. We have a few minutes left. I just want to say to all three of you, having been the victim of Big Bang implementations and doing Big Bang implementations, I think your strategy is probably one of the most intelligent I've heard of, because you get buy-in from your users and they get what they need, not everything in the kitchen sink that they don't need. This has got a lot of promise, and I sincerely hope that when we get this up on our website, more people hear it, you get more people asking questions, because this is just an incredible project you guys have gotten into.
Well, thank you very much. I would say to you two things, Chris. Adoption by the frontline staff is the most critical issue.
Absolutely.
I'll give you an example. Yesterday, we were deployed in a academic medical center, and they're not using our virtual sitting technology, but their entire virtual sitting system went down. We're using some other people, and we didn't tell them to. They put on, because it's deployed, they put our virtual system on for the unit it's deployed in, and watched all 32 patients with Infinity Watch without having to tell them maybe you should do that. They elected to do it, are seeing the results themselves. So we're not pushing it for them.
No.
This is being pulled, technology being pulled by frontline staff. That is, for me, the first time in my nearly 40-year career that I've seen technology be the frontline staff saying, I want to use this, and adding features on. I've never seen. So this feels like we're on the right track here.
Mm-hmm. Well, if we have no more questions, I'm going to thank Dr. Boutros, Dr. Su, and Mr. Singh. I really appreciate what you've done for us, and I think that we'll be hopefully hearing more from you soon. I think maybe this needs to be on our next conference in the spring for No Hymns. Have a full presentation, not just a webinar. That would be a nice thing to do. Thank you all, gentlemen.
We'd love to show it. We
Good,
would love to do
good.
it.
Thank you all for coming. We should have the recording up on the website. Give us till next week because our communications chair happens to be in Abu Dhabi and he has a little bit of a problem with time. So with that, I will thank you all and we will end the meeting.
Have a
Thank you
wonderful
very
day.
much.
Take care.
Bye, everyone. Thank you.